I'm going to be talking about electrical stimulation in Bell's palsy, and I'm Dr. MYRIAM LOYO. I'm a facial plastic surgeon in Portland, Oregon, in the United States, and I have a second speaker with me today. Tony DiPietro comes from the University Siglo XXI in Cordoba, Argentina. We've collaborated in a trial for electrical stimulation, and we're going to be doing this presentation together. So for our outline, we're going to start talking about Bell palsy and give you a clinical background on what this disease is like, which is particularly my forte. Then we're going to review the evidence for electrical stimulation for facial paralysis, following by a presentation of our trial and our results. And finally, Dr. DiPietro is going to present the technique for stimulation that was used in the trials, and when we'll wrap up with conclusions, hopefully all of that in time. So Bell palsy is the most common cause of facial paralysis. It affects 1 in 60 people during their lifetime, and the impact is significant. People are not able to protect their eye, are not able to breathe through their nose, are not able to control their mouth to the point where eating, drinking, and smiling becomes a big problem. In this photo, I've asked this patient of mine to smile, and you can see that the emotion she transmits is not one of happiness, but rather distress. And treatment to restore movement is important. Traditionally, we think of Bell palsy as a self-limiting disease that will recover and patients will have no sequela, but that's not the reality. Up to a quarter of patients, and possibly even more, are having problems past their initial flaccid paralysis. And there's a lot of things that we can use to predict which patients are going to have these issues. And in particular, the degree of paralysis and the time it takes to start seeing movement is a really strong predictor. In this chart, you can see that if patients don't have movement in the first month of their paralysis, their chance of developing sequela really goes much higher. In patients with incomplete paralysis that have some movement, most of those will recover well. So of course, we're familiar with the flaccid paralysis that I've talked about with the droop, but this is what synkinesis looks like. In this other side of the picture, we're asking the patient to smile, and her eye is closing down on her. She cannot elevate the corner of her mouth. Her chin is pulling, and her neck is pulling. And she looks a little odd, which people notice. So yes, we mostly talk about flaccid paralysis, but there's also this hypertonicity and synkinetic paralysis that's really important and much more common than flaccid paralysis. I didn't want to give this talk without also talking about the importance of steroids. There's really good evidence that steroids increases the rate of recovery and the final recovery of Bell's palsy. And there are several factors that can predict prognosis. I'm going to touch on those because I think these are the patients that we really should be concentrating on to do more interventions like electrical stimulation. So if somebody has incomplete paralysis, that's a really good predictor of full recovery. Young patients, particularly younger than 14, tend to do really well, though little is known about pediatric patients. And patients that are starting to see movement in the first 3 weeks are likely to do well. In the contrary, somebody with complete flaccid paralysis for longer than 3 weeks is likely to benefit from intervention. Patients who are pregnant when they develop Bell palsy have much worse outcome. Older patients, and although Ramsay-Hunt, which is associated with the varicella-zoster virus, is not Bell palsy but its own entity, it has a much worse prognosis. And after the blisters are recovered, they're also treatable by electric stimulation. It was interesting to hear others speak about how electric stimulation is feared because that's very much the attitude in the United States. We have very vocal therapists that talk against the use of electric stimulation for Bell's palsy or any type of facial paralysis. And so we did a survey to try and find out why that was. It was very interesting to see that the groups were very divided, with some people saying it really works and there's really clear evidence for it, and some people saying it really doesn't work and there's no evidence. And then another subgroup of people saying, I never learned how to do it, so I can't offer it to patients. So with this division of mind about how some people really believe in it and some people are really against it, we did a deep dive into the literature to try and find what the evidence is. And there's really 7, if you count our trial, 8 human trials with cases and controls looking at stimulation for facial paralysis, and all of them concentrate on Bell's palsy. 5 of the trials found benefit to the intervention and 2 no benefit. And the settings were very different. So some were biphasic, some were monophasic, mostly motor, but there was even a sensory trial. And in total, the number of participants is small, 447. The studies have limitations, low power. The follow-up is a critical one because most of the studies follow patients for 3 months, and we know that it takes 6 months to develop synkinesis. So they're missing that window. And in all of the studies, they were not accounting for the baseline presentation or the predictors of prognosis. In the way we measure outcomes by using the scale and how we analyze how patients are doing really needs to be refined. And blinding is really important when we're looking at human trials. So as we designed our trial, we were thinking about what settings to use. And I know everybody knows about it, but just wanted to touch on if we have a central lesion, the nerve is intact, we can do shorter pulse durations and neuromuscular stimulation. If we have a peripheral nerve lesion that is severe, the muscle will be denervated. And so we're really looking at direct muscle stimulation with greater than 10 milliseconds pulse durations. Or we could try using monophasic pulse current following the thought that it might enhance healing, in particular healing of the nerve. And as the peripheral nerve is recovering, then we have a mixed picture of partially innervated, partially denervated muscle. And we're all familiar with this, so I'm going to skip through and move towards our trial. So this was a trial that was done in collaboration with the Universidad Nacional del Noreste in Córdoba, Argentina. In it, 38 participants were recruiting, half into the stimulation group and half into the control group. For this trial, patients that had less than 1 month from onset had not received steroids, which is unusual, and patients that had incomplete paralysis were selected. In the control group, patients were receiving physical therapy, so they were having manual stretching and mirror therapy. And in the intervention group, people were receiving the electric stimulation plus the physical therapy. And the settings that we chose were monophasic exponential current. The pulse duration was adjusted to create contractions from 30 to 200 milliseconds. And we wanted patients to have 5 contractions per muscle group times 5 daily. And the average length of the treatment was around 20 minutes for the electric stimulation. So one of the very cool things about this study is that we followed patients not only after recovery, but 6 months post-recovery so that we can really look at synkinesis. And we used a much different score than what has been used in the past. So yes, we use a traditional house fragment that otolaryngologists are very familiar with, but we also added an E-phase score, and I'll tell you a little bit more about that. And what we found was the electrically stimulated group recovered twice as fast with an average duration of paralysis of 2.5 weeks versus 5.2 weeks in the control group. And the age and presentation, severity at presentation, and all of those were well matched. I'm putting this graph here just to talk a little bit more about our currents. So again, we really want the long pulse durations that several speakers have been alluded to when we're stimulating denervated muscle. This is a very busy graph looking at the E-phase score. So the E-phase score is a clinician-graded score. The inner study was blinded and evaluated by 2 separate researchers. And it gives you one global score, but it also gives you subscores for symmetry at rest, symmetry during movement or dynamic, and synkinesis. And in this graph, the control group is in red and the stimulation in blue. And you can see that the scores were bad and poor and recovered, as you would expect with Bell's palsy, in all in the static and in the dynamic areas. And they're not very different, but this data does suggest that there might be some improved dynamic outcomes with the stimulation. And here in the synkinesis, at the beginning, we have no synkinesis and really good scores. And as they recover, the patients develop some rates of synkinesis. And although we didn't find a significant difference, this data suggests there might be worse synkinesis in the control non-electrically stimulated group, contrary to popular belief. So now I'm going to switch to Tony so that he can tell us more and give us a demonstration about this technique. Tony's going to be presenting in Spanish, and I'm going to be translating for him. Tony, I think you're still, muted. Thank you. So let's see, maybe I should exit my presentation. And is it possible to please make his screen bigger?
Un poquito de sueño y dentro. Perfecto.
Lucas, Tony, we're ready for you.
Tardes desde Argentina, Córdoba.
Good afternoon from Argentina, Córdoba.
Estamos explicando la técnica. Un electrodo está en el brazo.
We are explaining the technique. Our grounding electrode is in the therapist's forearm, as you can see.
El otro electrodo en la cervical del paciente.
And the other electrode is in the neck of the patient, as shown here on the blue pillow.
En cada pulso se estimula el músculo que voy a trabajar selectivamente.
During each pulse, we're using our fingers to selectively identify the muscle that we're going to stimulate. So Tony, I saw there that, Tony, ahí vi cómo se cerraba el ojo y cómo creaste la, yeah. So here you can see how he's using his fingers around the nasolabial fold, and he's getting contraction of the mid-face levators, and the lip is coming up. He's coming down, and you can see the contraction likely of orbicularis oris. And when he separated his fingers like he did around the eye, I could see eye closure. So it's possible to separate your fingers in the upper and lower lip to get more of the purse and lip kiss movement.
El recorrido, 5 contracciones por punto, 5 veces.
And he likes to stimulate 5 contractions per each step and do it 5 times. You can see there frontalis being stimulated.
Si trabajaría el lado sano, no responde.
And when you move towards the unaffected side, the settings are not effective.
Solo responde el lado afectado.
So the settings are really developed for the affected side.
Si bajo el pulso, cambia la calidad de la respuesta motora.
And some of the adjustment the therapist is making is the pulse width. So as he plays with the pulse width, he can see the difference in the contractions. And we're trying to use the ideal pulse width where we have a good quality contraction and the patient tolerates it well, and use the least long that generates a good contraction.
Busco el mejor ancho de respuesta motora y es el que trabajo con el paciente. Por eso es selectiva.
So part of the selectivity is not only on identifying the trigger point and the place where the finger placement creates more contraction, but also the duration of the pulse that creates the most effective contraction. Tony, ¿quieres hablar de intravocal?
Puede ser, sí, ahí lo hacemos.
Y
Le desinfecto la mano primero.
Ok, ¿y tu voluntaria quieres platicar algo de la patología para lo que lo estás usando?
Sí, en este caso estamos usando una paciente que ha tenido un tumor en la parótida con la parálisis. Obviamente estamos usando de ejemplo para la técnica ella ha venido en estado agudo y tiene una recuperación en estos momentos casi de un 50 al 60% de cómo llegó.
Okay, so in this case, our lovely volunteer has a parotid tumor with transection of the facial nerve. And what Dr. DiPietro is trying to show you right now is his technique for intraoral stimulation. So he right now is targeting, so as I saw the lip contract, he was targeting oris, but this is one of his preferred methods to target buccinator and to target zygomaticus muscle. So here when he pushes towards the nasal tip, he's targeting oris. And when he goes towards the malar eminence, he's creating zygomaticus contractions. The facial muscles are rather small. They're a few millimeters in thickness. And sometimes the intraoral stimulation is where he's able to complete the circuit to get those muscles to contract. So he's not able to wear gloves, or that would shorten the circuit, but he asked the patient for permission, disinfected his hands, and this is how he does this intraoral portion.
Creo que más o menos estaría explicado, Miriam, la técnica.
Más o menos, pero si quieres decir cualquier cosa.
Ajá. Sobre todo, entender que la corriente unidireccional es la que me permite esta selectividad de trabajar no en grupos musculares, sino selectivamente por músculo.
Okay, so Dr. Pietro is saying because it's a unidirectional current and the exponential ramp will improve tolerance and it'll help with the selectivity. Tony, ¿qué grupos musculares trabajas normalmente para parálisis facial?
Bien. El facial tiene 3 fases, en la cual siempre la frontal, la media y lo que sería la bucal o inferior. En una parálisis facial, lo primero que se trabaja es de arriba hacia abajo y la respuesta también generalmente es de arriba hacia abajo en la progresión, llegando al promedio en una parálisis de Bell de más o menos 8 a 12 sesiones la recuperación.
Y las haces diarias, ¿verdad?
Sí, dosis diaria, 5 repeticiones por punto, 5 veces.
Yeah. I imagine a lot of our audience speak Spanish, so they probably are understanding. And when I'm translating, I'm adding a little bit of my opinions in there. But Tony's saying that in Bell palsy with incomplete paralysis, it typically takes them 8 sessions. In Argentina, it's easier for the patients to come for daily sessions than it is to do home therapy. I did listen to Dr. Ashraf's talk with great interest because here in the United States, it's easier to do home therapy, but 8 to 12 sessions for incomplete palsy. And then Tony thinks about the facial nerve having 3 main branches. As a facial nerve surgeon, I disagree. There's like multiple branches, but that helps him think about how he needs to spread through the face. He likes having a systematic approach, starting from the top and going towards the bottom of the face. And he feels that he starts seeing more robust contractions in the frontalis first, and then later the lower facial muscles will come.
Miriam,
Sí.
Me parece importante detallar que se trabajó con 412 pacientes, de los cuales hemos seleccionado para el trabajo los últimos 38 que no tengan diabetes, hipertensión, no sean tratados con medicamentos y no tengan antivirósicos.
Yeah. So Tony says that the center's experience with treating Bell palsy with electric stimulation is larger, is over 400 patients. But for this study, we didn't do an intent to treat analysis, but rather a per protocol analysis. So patients that didn't have diabetes, didn't have a hypertension, were not on immunosuppressants. So patients that felt more homogeneous and controlled for other confounders of the outcome were included. Tony, I think the demonstration, Tony, creo que la demostración ha estado muy bien. ¿Quieres hablar de tus diapositivas o paso a las conclusiones? Sé que la mesa directiva ha estado muy preocupada por el tiempo.
Exacto. Seguí, Miriam, vos. Creo que está bien lo mío. Está bien.
Ok,
Saludos
muchas
nomás.
gracias y gracias a la paciente que nos dejó aprender con su estimulación.
Exactamente. Exactamente. Ella tenía su sesión diaria hoy día y le agradezco que haya venido en horario este para poder acompañarnos.
Okay, perfect.
Saludos.
So
No,
I am a
gracias a
bit
ustedes y que sea para bien.
gracias. I'm a bit unsure where we are with time. I've asked through the chat to the team leaders how much time I have left, but because I'm a bit worried, I'm just gonna keep going, and then hopefully we'll have some time for questions. So this is more about the stimulation that you've already seen. This is a different patient that was actually included in our study. You can see frontalis there, and then they move towards the lower part of the face. And you can see now more of the upper lip and mid-face, mentalis. So you get the idea of the protocol. The intraoral was new for me, and Tony was able to describe that very well. So as I move to our conclusions, Bell palsy is a common disease. Electrical stimulation for Bell palsy is safe and does not appear to increase the risk of severity or risk of development of synkinesis. Facial paralysis due to peripheral nerve injury like Bell palsy can be treated with DC or exponential currents to produce contractions of the denervated muscle or monophasic pulse currents to promote nerve healing. Further research is needed with larger trials. We need to include patients with poor prognosis in those trials. It needs to be well blinded, and the EFACES is a scale that allows us to do that. And it's important to treat patients with steroids and include that in trial design. There are new tools to evaluate the outcomes in a very objective way for facial paralysis, and we highly encourage the use of EFACES or the Emotrix software. For our study, high quality videos were collected at enrollment, at discharge from treatment, and at the 6-month follow-up, which really allowed us to do some very in detail analysis. So we wanted to open it for questions and thank our collaborators, including the Medical Research Foundation of Oregon, the PT center that Dr. DiPietro works at Fisiocero, Dr. Cameron and Dr. Campana, and the therapists and patients that enrolled in our trial.